Check, check. Hello, hello.
हेलो अस्सलाम वालेकुम 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 हेलो अस्सलाम
हेलो
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 उस्मान भाई आपको आवाज आ रही है मेरी
हेलो
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 आपको आवाज आ रही है भाई?
आवाज आ रही है
हेलो
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 उस्मान भाई आपको
मान
आवाज
भाई
आ रही
आपको
है?
आवाज आ रही है?
सेकंड जी आवाज आ रही है लेकिन अभी भी स्टिल जो है ना वो इको साउंड है। रिपीट हो रही है बार बार।
उस्मान भाई मेरी आवाज आ रही है
जी
आपको?
आपकी आवाज आ रही है लेकिन आवाज रिपीट हो रही है कुछ चार चार पांच पांच दफा।
इको हो रहा है सर आवाज
ये स्लाइड भी कीजिएगा रज़ाक भाई स्लाइड पे जाइए वो डायरेक्ट
मतलब अगर आप कंटिन्यूसली बात करेंगे ना तो कुछ समझ नहीं आएगी कि क्या कह रहे हैं।
हाँ 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 नहीं 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 नहीं
जी अस्सलाम वालेकुम तस्वीर से नहीं आ रही है सर कम नहीं आ रही है यार यार इनवाइट
मेरी भी तो आ रही है 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 मेरी भी तो आ रही है
अभी भी आपकी आवाज इको है।
हाँ मैं आईफोन खत्म कर दिया लड़ाई हो गई S25 जी उस्मान भाई अभी कैसे इसका पोर्ट्रेट ले
आवाज
लो ज्यादा अच्छा है
पिक्चर बिल्कुल ठीक
नहीं
है
नहीं पोर्ट्रेट
लेकिन जो आपकी
स्टिल ठीक
आवाज है
हाँ
वो इको हो रही है।
उस्मान भाई अभी आप हो
जी जी
हलाई 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 और खोलता हूँ ना
ठीक है दिखा
ये नहीं हलाई हलाई
जी अस्सलाम वालेकुम जी
बढ़ा दे और बढ़ा
जी अस्सलाम वालेकुम
हेलो क्या नाम था इसका उस्मान भाई अब आप बोलिएगा दोबारा आवाज़ नहीं आ रही ना आवाज़ फिर बंद हो गया हेलो साउंड चेक कम करें अच्छा उस्मान भाई आवाज़ आ रही है अब आपको
जी आवाज आ रही है और अब क्लियर है, ठीक है।
जी ठीक है जी जी
जी अस्सलाम वालेकुम उस्मान भाई, मैं अगर आपको आवाज आएगी मैं
वालेकुम
वन कहूंगा,
सलाम।
आप टू कह दीजिएगा।
जी
जी
अभी क्लियर है आवाज।
अभी क्लियर है?
हाँ जी, हाँ जी क्लियर है।
ठीक है, अब सेम है? हेलो जी उस्मान भाई,
ठीक है।
चलिए अंदर आ जाए आप। ठीक है, ओके।
जी जी अब ठीक है आवाज।
अभी एक मिनट बल्कि रुके जरा।
जी आपकी आवाज आ रही है, अब आपकी आवाज ठीक है।
चेकआउट कितने बजे? 12 बजे। तो सेशन कितने बजे खत्म हो? 11 बजे तक करना है खत्म, क्योंकि मैं आगे लाहौर जाना है।
टाइम लेट हो जाएगा। अभी वो ओहियो से थे और वहाँ पे तो अराउंड कोई 10:30 हो गए।
हाँ इट्स
मैंने
नॉट।
उनको बताया मैं कि यहाँ पे थोड़ा सा लेट शुरू करेंगे। और स्क्रीन शेयर मैंने उनकी तीनों की चेक कर ली, सिर्फ सोबिया की रह गई है। सोबिया की वैसे भी लास्ट प्रेजेंटेशन है।
सब ब्रेकफास्ट कर रहे हैं। 7:15
डॉक्टर्स काफ़ी थे ब्रेकफास्ट पे।
7:15 पे लोग आए हुए थे, उन्होंने ओपनिंग, मैं खुद वहाँ पहुँची हूँ तो कहती थी अभी हमारा बूफे रेडी है। मैंने कहा भाई हमने इन लोगों को 8 बजे का
तो 7 बजे इन्हें टाइम दिया हुआ था।
नहीं 7:30 के बाद खोला है इन्होंने, तो अभी फिर लोग जाके फिर दोबारा वापस आए।
इस बार हमने देखा ये पीसी का स्टैंडर्ड यही है, उनके रूल भी थोड़ा पहले से। हाँ तो ये मेरे ख्याल ये साथ साथ रेनोवेट नहीं कर रहे।
पीसी भुरबन शुरू से ही ऐसा है, कॉफ़ी तो खाना बहुत बेहतर होता है। फूड पॉइजनिंग नहीं हुई आपका? 24 घंटे हो गए
हाँ,
आप
वैसे इनका खाना
नोटोरियस हो।
अच्छा, शुरू में जो है वो आप ही मॉडरेटर को भी पहले आप पैनलिस्ट को आप ही इनवाइट कर लीजिएगा, फिर फैसिलिटेटर
पैनलिस्ट में हमारे कौन कौन है?
मैं आपको स्लाइड दिखा देता हूँ।
एक तो अल्ताफ आलम साहब हैं। बिलाल हमीद साहब नहीं है मॉडरेटर?
मॉडरेट वही करेंगे क्योंकि वो भी सीनियर है, तो एज
हाँ।
हमने इनको ना फैसिलिटेटर रखा है। हम पहले इसलिए जो वो हमारे
एक्सपर्ट पैनल्स
पैनलिस्ट
को
हैं,
बुला
हाँ,
के फिर बिलाल साहब को ओवर
फिर उनको
ठीक हो
उनको
गया।
दे देंगे, फिर आगे वो सारा सेशन वो चला लेंगे। और
काम
hello, hello, check, check, check.
वो इसकी ना पतियों में भी वहाँ। वो सेंट्रल एक आदमी है जो साथ खाली प्लॉट है, वो उसका केयर टेकर, उसकी फैमिली को हम लोग काम करते हैं, उसके बच्चों को हम पढ़ाते हैं, तो हम सपोर्ट करते हैं। तो उसकी बेटी ऐसे कर रही है और बेटा मैट्रिक में है, और शुरू से हमने उनको उनकी फीस वगैरह सारी हम यूनिफॉर्म बुक सब तो वो बंदा जो है ना वो लुका और वो पूरी फैमिली जब हम जाते हैं तो हमें लुका मतलब वो मियाँ बीवी 3 बच्चे उसके, वो सारा घर के कवर करते हैं, सफाई खाना पकाना सब कुछ। यहाँ पे सबसे बड़ा प्रॉब्लम होता है ये अंडरग्राउंड करती पूरी तरह पहला जो था फिर हमने दोबारा बोल दिया, लेकिन फॉर्चुनेटली वो पानी जो है ना केबल ही मिलेगी जो दोबारा कराया
हेलो 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 हेलो
पूरा इलाका इस्तेमाल हमारा एडवांटेज ये है कि वो अगर सामान आते हैं तो किराया पड़ता है,
हेलो 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 ठीक ठीक
ठीक है हमारा भी फायदा है उसका भी।
उस्मान भाई आप कहाँ पर हैं?
मैं हॉल में हूँ।
आ जाए अंदर, आ जाए अंदर आ जाए आप।
जी मैं हेलो
हमने काफी उसके पैसे पूरे कर लिए, हम बहुत रहते थे वहाँ पर। जब बच्चे छोटे थे तो आपको पूरा समर याद था, वो आ जाते थे, मैं चला जाता था, फिर मैं भी आते रहता था, और 2-2 महीने यहाँ पे टाइम गुजारते। लेकिन फिर वो आहिस्ता आहिस्ता बच्चे सारे चले गए, बुढ़ा बुढ़ी रह गए हैं अब।
जो मेरा बेड है, ये जो मेरी चीजें हैं, तो वहीं पर मैं खुश हूँ।
बिल्कुल ये हर एक का ही है, किसी और बिस्तरे पे नींद नहीं आती। क्योंकि हम घर पे कोई भी 2 ही बंदे हैं ना, तो वो फिर ये जो पैक्स होते हैं ना, ये बड़ा काम करते हैं, इनका इंतजाम बहुत मुश्किल। अब उसकी वजह से हमने अपने घर के सर्वेंट क्वार्टर में लाहौर में रखा हुआ है, तो हम कहीं जाएं तो वो बड़ा मुश्किल। हाँ, अच्छा ये जो कुत्ता तो खैर बाहर होता था, उसकी डेथ हो गई। बिल्लियाँ अंदर घर के अंदर होती हैं, ये वो तो घर के मालिक होते हैं। बिल्कुल। तो पहले जब हम मरी आते थे ना, तो इस्लामाबाद में एक राना वेट की सर्विस है, बहुत मशहूर है, तो उसका एक हॉस्टल भी जो वो बिल्लों को रख लेता। तो 1-2 दफ़ा हमने वहाँ पे रखा और खुद यहाँ आ गए, फिर वापसी पे लेते गए। तो फिर हमने समझाया कि नहीं, इसको घर से ना डिस्प्लेस करो, इंतजाम कर लो कि इसको कोई डॉक्टर घर पे जाए। बहुत अपने वो घर वाली बात आप कर रहे हैं ना, तो हमसे ज्यादा ये बिल्ले करते जो है ना, ये अपने घर पर वो बहत रही वो 3 महीने की वो ठीक हो रही लेकिन वो काफी तो उन्होंने जो है ना एक 2 बिलियन अस्सलाम वालेकुम, क्या हाल है बेटा, कैसे हो, ठीक हो? माशाल्लाह आपका प्रोग्राम ठीक
ये कर
चल
दो
गया।
यासर भाई, ये हो गया इधर इधर।
थैंक यू बेटा, बड़ा मेरी ग्रैंड डॉटर है वो, मेरी बेटी जब आती है ना तो वो ग्रैंड डॉटर तो वो बिल्ले के ऊपर ही रहती है सामने में, तो मुझे कहती है कि तुम्हें तो पता है, कहती है इसका पासपोर्ट बनाओ, इसका वीजा लो और इसको साथ ले जाओ, तो पीछे पड़ी रहती है कि वो मेरे साथ। मैंने कहा तुम्हारे छोटे छोटे वहाँ घर है नहीं 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 जी, आप तशरीफ रखें जी हजूर, आप ही की जगह। अस्सलाम वालेकुम, क्या हाल है? हमारा तेरा कौन
हेलो हेलो माइक टेस्टिंग 1 2 3 हेलो हेलो माइक टेस्टिंग हेलो 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 माइक टेस्टिंग 1 2 3 हेलो माइक टेस्टिंग हेलो माइक टेस्टिंग 1 2 3 हेलो
हेलो हेलो
तो फिर अपराध ग्रुप बीच में आ गया, उन्होंने कहा ये हम इस प्रोजेक्ट को कर ले लो, फिर हमने शेयर भी इसमें कुछ डाले, फिर वो अपराध ग्रुप कोलैप्स कर गया, बैंकरप्ट हो गया, फिर उसकी कोर्ट के थ्रू लिक्विडेशन हुई उसकी सारे एसेट्स की। तो जो हेल्थ केयर था वो एक अमेरिकन कंपनी है टीपीजी, उसने खरीदी। तो अब ये टीपीजी ओन करता है, हमारे पैसे भी उन्होंने वापस कर दिए, हम किसी को शेयर नहीं देंगे, हम अपना उनके पास पैसे की कमी है। तो फिर वो उन्होंने बेसिकली अब ऐसे ही है जैसे हॉस्पिटल है, जैसे काम आप लेकिन आई होप कि जूनियर्स भी कभी भी नहीं होता। मैं शेख ज़ैद में 27 साल काम किया है, 8 बजे हॉस्पिटल शुरू होता था, आई वॉज देयर एट 7:30। तो सारे कहते थे कि हमारी ज़िंदगी गुजर गई कि हम आपकी गाड़ी देखते हैं कि पार्ट है, हम उससे पहले नहीं पहुंच सकते। मैंने कहा कि करो लेकिन हो ही नहीं सकती, वो आप 5 मिनट पहले आ जाओगे तो 10 मिनट पहले आ जाओ, हमको पता है। बस कुछ लोग ऐसे होते हैं। वो एक सर्जन होता था, अभी भी है, अबुल फजल, लाहौर, वो जिस वक्त हम निकलते थे सड़कें खाली होती थी, तो वो मुझे हमेशा ट्रैफिक लाइट पे मिलता था और शीशा नीचे करके कहता था, और पूरे लाहौर में कोई डॉक्टर अस्पताल टाइम पे नहीं जा रहा, मैं और आप हमेशा मिलते हैं। जी काफी
हेलो Bismillahirrahmanirrahim. Ladies and gentlemen, once again a very warm welcome to all of you to day 2 of our Liver Summit, the Best of AASLT debrief session. And we formally begin today's program with the recitation from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفره إنه كان توابا صدق الله العظيم.
Jazakallah, thank you very much. Once again, ladies and gentlemen, on behalf of the entire Ferozans team and the faculty of the Liver Summit, we warmly welcome you to day 2 of our session, the Best of AASLD debrief session. For starting the session, I would request our respected panel of experts to please come and grace the stage. Professor Dr. Altaf Alam, Professor Dr. Javed Iqbal Farooqi, Dr. Muhammad Saleh, Dr. Zishan Ali, and Dr. Qayasun Nabi will inshallah join us shortly. And now I would like to hand over the stage to your moderator for the day, Dr. Bilal Hamid.
Assalamu alaikum everyone. I hope everyone had a good night and sleep and then had a good breakfast. I saw many of our colleagues still eating breakfast. Hopefully they will gonna join soon. For the last couple of years, I was talking to Ferozan and Usman and PSH and all the other organizations about it's getting very hard for Pakistani faculty to come to US for AASLD. It's very expensive, visa issues. So we thought that we can start doing the best of AASLD, very high yield impact, what was the best abstract, what are the updated information and the changing in the field of hepatology. It was very successful. The last couple of times I was also virtual. This time I was traveling to Pakistan to work out. But we have this amazing faculty from Canada and the US. And without further ado, because of the time difference, they are online waiting for us, so we want to be on time. The first faculty member I wanted to introduce is a rising star in hepatology, Dr. Qasim Khan. He is a graduate from King Edward, but has gone to many different amazing places, including Mayo Clinic, and now is an assistant professor at Western Ontario in Canada. He's an amazing researcher. Last year, he did talk about update on cirrhosis and portal hypertension, very well received. So I will kind of pass on to Qasim, and then he will talk about his best abstract, and we will have about 10 minutes of question and answers. So Qasim, go ahead, and thank you for joining.
Welcome, everyone. Very good morning to everyone, and thank you all for being here so bright and early. I do thank you, Dr. Hamid, and the organizers for inviting me yet again to the Best of ASLD Pakistan 2026. I found it to be a very enjoyable experience last year. I spoke about cirrhosis and portal hypertension last year, and this is what I'll be doing this year as well. Can you just let me know if you can see my screen? I'm assuming you can. Okay. So thank you once again. Here are my relevant disclosures. Just in the interest of time, I thought we'd just jump right into the meat of it. So just before we get started with the abstracts and the key studies that I wanted to highlight, I just wanted to go over the process through which I selected the abstracts that I'll be presenting. I simply had three criteria, and that's what I was looking for in some of these studies. The first and foremost was novelty of the clinical question and the research question. The second was, will these results potentially change my practice? Do they have the capacity to change what I'll be doing now or in the future? And third was just the rigor and the effectiveness of the research design and the research methodologies. And these were the three main criteria that I used. Of course, portal hypertension and cirrhosis is a very large topic, so I had to limit myself to just the top 5. So my apologies if you were hoping that I would highlight a particular study, but I felt that this was probably the group that was worth discussing. So start off with the first presentation, the first abstract, and that was dapagliflozin can reduce the incidence of chronic kidney disease in MASH cirrhosis patients with moderate ascites. So we're all aware of the effect that decompensated cirrhosis can have on the kidneys. I don't think we need to reiterate the physiology here, but patients with MASH in particular have an independently increased risk of chronic kidney disease. It's about 1.5 times greater than the general population based on a recent systematic review and meta-analysis. And so it's important to discuss this in this subset population. Dapagliflozin, as you're all aware, is an SGLT2 inhibitor. It's an agent that has conferred many cardiorenal benefits in multiple studies. It acts on the proximal tubules of the kidneys and not only promotes glycemic control, but promotes natriuresis, which reduces blood pressure, glomerular pressure, and in turn helps with volume dynamic management as well. There have been some small studies recently in the last few years that have shown a potential signal that dapagliflozin can help with management of ascites in cirrhosis patients. But in terms of the ability of dapagliflozin to mitigate the risk of developing kidney injury, that has not specifically been studied. So this group of investigators, they sought to answer the question that can dapagliflozin be safely and effectively used in patients with MASH cirrhosis and moderate ascites to prevent the development of chronic kidney disease. So this was a single center open label study that was conducted at the Institute of Liver and Biliary Sciences in India. They identified patients with MASH cirrhosis and moderate ascites who were on diuretics. They identified a total of 144 patients, and they planned to randomize them in a 1-to-1 ratio to either receive dapagliflozin and standard of care, starting with a dose of 5 milligrams and up titrating to 10 milligrams, and they compared that to a standard of care group. So about 72 odd patients in each group. These patients had a similar baseline characteristic profile in terms of sociodemographics. They were followed for a total of 12 months. The primary endpoint, as the title suggests, was the development of chronic kidney disease defined as a GFR less than 60 for 3 or more months at 1 year. Secondary endpoints were CKD development at interim time points in between, acute kidney disease, resolution of ascites, metabolic changes, and of course, drug-related adverse events. So what they found in terms of the outcomes is this, if you just focus your attention to this portion of the bar graph here, in terms of development of chronic kidney disease, you'll see in the lighter pink that only 8% of individuals on dapagliflozin develop chronic kidney disease compared to 26% in the standard of care. This was found to be significant. A greater proportion of individuals on dapagliflozin achieved ascites resolution compared to the standard of care as well. Not mentioned here, but about 60% of patients on dapagliflozin achieved with complete withdrawal of diuretics compared to 29% in the standard of care group as well. In terms of metabolic benefits, as can be imagined, dapagliflozin did confer an improvement of hemoglobin A1C, but it's important to note that it also effectively reduced the incidence of acute kidney disease, and patients on dapagliflozin tended to have a better GFR compared to those on standard of care. In terms of adverse events, we do get worried about genitourinary infections with glycosuriin on dapagliflozin. There were 3 cases of genitourinary infections, with 2 of them requiring discontinuation. But overall, this study suggests that dapagliflozin can improve ascites control without significant renal or metabolic compromise, and it appears to be safe and well tolerated as an adjunct in cirrhosis with moderate ascites. Of course, greater multi-center studies in a blinded fashion are necessary to validate these findings. Moving on to the next study, this was abstract 5021, short-term human albumin therapy improves serum sodium and reduces mortality in patients with cirrhosis and dilutional hyponatremia. This was the ALBUCAT trial. As we all know, and we manage patients with decompensated cirrhosis in the hospital quite frequently, and hyponatremia, particularly hypervolemic hyponatremia, is a part and parcel of this disease. And with the exception of withholding diuretics and fluid restriction, potentially doing large volume paracenteses with appropriate replacement of albumin, we don't really have a lot of studies or interventions that we can do. There have been some cohort studies and some retrospective studies showing potential benefit of albumin for short durations, but never been done in a randomized controls trial setting. So these individuals asked the question that can IV albumin therapy in hospitalized patients with decompensated cirrhosis effectively resolve hypovolemic hyponatremia, which they define as a sodium less than 133. This was a multi-center study conducted in over 8 centers in Spain, an open-label randomized control trial. They identified individuals with decompensated cirrhosis and hyponatremia who were hospitalized. They identified a total of 52 patients. Median age was about 61 years. Most of them were males, and the predominant etiology of liver disease in almost 3/4 of individuals was alcohol-associated liver disease. These patients were then randomized in a 1-to-1 fashion to either receive albumin and standard of care or just standard of care alone, which comprised fluid restriction and withholding of diuretics. In terms of the regimen for albumin, they were given albumin for a maximum of 10 days while they were at the hospital. The day 1 dose was 1 gram per kilogram of body weight in divided doses, and this was followed by 40 grams per day thereafter. After these patients were followed, the primary endpoint was resolution of hyponatremia, which they defined as an improvement of 5 milliequivalents with a final value greater than 130. Secondary endpoints included just frequency metrics of resolution of hyponatremia, partial resolution, which was defined as an improvement of 5 milliequivalents per liter, but not achieving a finite value greater than 130. Development of major reverse liver outcomes, and overall survival. The results shown here, I forgot to mention earlier that the metrics of these patients, apart from the demographics that I mentioned earlier, the median MELD was 17. The median serum sodium at the time of presentation was 128 milliequivalents. Looking at the primary endpoint of resolution of hyponatremia in the albumin versus standard of care arms, as you can see here, a greater proportion, almost 50% of the patients who received albumin were able to achieve resolution of hyponatremia versus 15% in the standard of care arm, and this was found to be statistically significant. Interestingly, there was also a small signal for mortality benefit at 28 days of these hospitalized patients, with no patients receiving albumin suffering from death, compared to 5 individuals who were in the standard of care arm, and this was also found to be statistically significant. In addition, there was a lower incidence of acute kidney injury in the albumin arm compared to the standard of care arm as well. So overall, this study suggests that in hospitalized patients with decompensated cirrhosis and hyponatremia, short-term IV albumin is associated with higher rates of resolution of hyponatremia, improved survival at 28 days, and a lower incidence of acute kidney injury compared to standard treatment with just diuretic withdrawal and fluid restriction. Moving on to our next study, this was a late-breaking abstract, and this was the much awaited aseptic clinical trial. So this was cotrimoxazole for patients with cirrhosis and ascites and no prior spontaneous bacterial peritonitis. So we're all familiar with the data and the very strong recommendations for individuals who suffered a previous episode of spontaneous bacterial peritonitis that they should receive antibiotic prophylaxis. But what has come under question or under the microscope now are some of the recommendations that were in the earlier guidelines by the ASLD and EASL with regards to primary prophylaxis with antibiotics, specifically in individuals with ascites and total protein less than 1.5 grams per liter. And this dates back to the initial studies by Bruce Runyon and group in 1996, where they showed that individuals with an ascitic protein level less than 1 gram per liter had a 10 times greater risk of developing SBP. This was followed by multiple studies, including a landmark study in 2007 that looked at norfloxacin versus placebo in patients with an ascitic protein level less than 1.5 and evidence of liver or renal dysfunction. And they found that norfloxacin improved survival at 3 months and at 1 year and reduced the incidence of SBP. However, in the last few years, there's been further insight has been revealed with regards to the methodologies of some of these studies, and it has been found that they were flawed in terms of the potential analyses, missing competing risks for death, in addition to some of the studies, including individuals who had prior SBP, even though the studies were intended to be for individuals who had not had SBP. And this was the essential guiding force behind designing the aseptic trial. So this was a study that was done in over 40 centers, and they asked the question as to whether or not antibiotic prophylaxis with cotrimoxazole in cirrhotic patients with ascites and no prior history of SBP can improve overall survival. So, like I mentioned, this was a multi-center, double-blinded, placebo-controlled RCT conducted in the United Kingdom between 2020 and 2025. 41 centers participated. They had an impressive 442 patients. And these were patients with cirrhosis and ascites who were either on diuretics or who were receiving frequent large volume paracenteses. These were individuals who had not had prior SBP. These individuals were then randomized to either receive cotrimoxazole at 960 milligrams per day for 18 months or a placebo, almost in a 1-to-1 ratio. So there were a total of 219 on the drug and 223 on placebo. They were followed for 48 months with a primary endpoint being overall survival. I'm not sure if you can see this clearly or not, but this is essentially a Kaplan-Meier curve. And as you can see, the lines are quite parallel and they're crossing, suggesting that there was no significant difference in overall survival at the end of the 48-month period between those who were on antibiotics with cotrimoxazole compared to placebo. When they did adjusted analyses, adjusting for potential confounders like transplant listing, rifaximin use, etiology of liver disease, they also found that this was not significant. In terms of incident SBP, while the hazard ratio was above 1, this was also not found to be statistically significant, meaning that cotrimoxazole use did not confer any reduced risk of incident SBP. They did a subgroup analysis, and this was a sensitivity analysis specifically in patients with an ascites protein level less than 1.5, essentially trying to compare this to individuals in the Fernandez trial of 2007. They had about over 150 patients who met this criteria, and they again noted that there was no statistically significant increased risk of mortality in this subgroup, despite the fact that they were on antibiotics. So overall, this was the largest trial of primary prophylaxis done to date for patients with cirrhosis and ascites, and they found that cotrimoxazole had no effect on overall survival, thus potentially favoring an abandonment of this practice. Moving on to our next study, this was abstract number 66, differential effects of vasopressin and terlipressin as an adjunct to vasopressors on hemodynamic parameters in patients with cirrhosis and septic shock. This was the final analysis of the vital CRCT. I apologize, I have a spelling mistake here. And so individuals with cirrhosis who are critically ill and present with septic shock, of course, are at high risk of ACLF and multi-organ failure, while the initial agent of choice after fluid resuscitation is norepinephrine. You have other options in the form of vasopressin and terlipressin that come after the fact, but head-to-head comparisons of vasopressin and terlipressin have not necessarily been done as profoundly in this space. And so these individuals ask the question as to how does vasopressin compare to terlipressin with respect to safety and efficacy as a second-line agent after norepinephrine in this very sick group of patients with cirrhosis and septic shock. So this was also a single center study coming out of India, an open label RCT, I need to highlight that. They identified patients with cirrhosis with critical illness and septic shock who were not responsive to norepinephrine. It wasn't very clear in the abstract what that was defined by. They had a total of 120 patients, and these patients were randomized in a 1-to-1 ratio to either receive vasopressin. This was as a continuous infusion of vasopressin at 0.03 units per minute compared to bolus of terlipressin at 1 milligrams over 24 hours, which I found to be a little infrequent. And they followed these individuals with the primary endpoint being reversal of shock at 6 hours, but they also looked at reversal of shock at multiple other time points at 3 hours and 72 hours, including other important hemodynamic and biomarkers such as lactate clearance and systemic vascular resistance improvement, and also looking at adverse events and rebound hypotension. When you look at the demographic profile, the mean age of these patients was 47 years. Almost all of them were male, and 41% of these individuals had alcohol-associated liver disease. So it does bring into question the external validity of these potential findings, which I'll go over. But in terms of the primary endpoint, between terlipressin and vasopressin, there was no statistically significant difference in reversal of shock at 6 hours, nor was there any significant difference with reversal of shock at 72 hours. Interestingly, there was a potential for more rapid reversal of shock at the 3-hour mark, being statistically significant with terlipressin compared to vasopressin. But otherwise, vasopressin appeared to be superior with respect to a more favorable lactate clearance, improvement of systemic vascular resistance, a lesser propensity for adverse events, and less frequent rebound hypotension. In terms of why this rapid reversal was seen at 3 hours, like I mentioned, terlipressin was given as a bolus as opposed to a continuous infusion. That may be one of the reasons. Plus, they're looking at multiple analyses, and so multiplicity can also be a potential factor here in such a small number of events. Overall, terlipressin and vasopressin, with the exception of that rapid reversal element that we found, they're largely comparable with respect to their hemodynamic effects, but vasopressin appears to confer less adverse events, less rebound hypotension, and more favorable physiological and biomarker profiles. I do think that this question needs to be studied in a multi-center setting and not with an open label. And it can be done in a blinded fashion, and potentially even using continuous infusion of terlipressin versus vasopressin as a continuous infusion as well. Moving on to the last study, this was abstract number 2342. Higher platelet counts define a low-risk subgroup among recompensated Hep B cirrhosis of propensity matched cohort study. Recompensation is certainly a hot topic in cirrhosis and portal hypertension as defined by the Baveno 7 criteria. These are individuals who have achieved a cure or at least stability of their underlying etiology of liver disease. They've had at least 12 months of no clinical decompensation, so resolution of ascites, not on diuretics, no hepatic encephalopathy, off of lactulose and rifaximin, and no variceal bleeding. And these individuals continue to have improvement of their liver synthetic functions as manifested in their MELD scores and CHOP-Q scores. So in this group, wanted to ask the question as to whether the long-term prognosis of patients with Hep B cirrhosis who achieve recompensation is comparable to that of compensated cirrhotic patients. And they also wanted to explore what are the predictors of adverse outcomes among the recompensated patients and certain factors or predictors that can help distinguish between those who have a more favorable profile as opposed to those who don't. So this was not a randomized controlled trial, but this was a cohort study where individuals were identified from a retrospective cohort of individuals with decompensated cirrhosis and a prospective cohort of patients with compensated cirrhosis. There were 10 centers in China, 1 center in the United States. They identified individuals who had Hep B cirrhosis and who were on a first-line nucleotide analog. They then identified those individuals who had achieved recompensation and also individuals who were already compensated. There were a total of 223 patients who had achieved recompensation, and these were propensity score matched to 859 patients who were compensated. In terms of the timing of when they were matched, the recompensated patients were matched at the time of recompensation, and they were matched to individuals who were compensated but who had been on therapy for at least 1 year or at 1 year. These patients were followed for at least 12 months, but the median follow-up time was 45 months. The overall endpoints that we're looking at were overall survival in the recompensated and compensated groups, the development of liver-related death, decompensation, and hepatocellular carcinoma. If you divert your attention to this figure here, this is probably the most high yield. As you can see here in these survival analyses curves, this one here is for HCC with recompensated group being represented in the tan here, and the compensated group represented in the green. You can see that there is a statistically significantly greater risk of a cumulative incidence of HCC in the recompensated cirrhosis group compared to the compensated cirrhosis group. There's also statistically significantly greater risk of decompensation in the recompensated cirrhosis group compared to compensated cirrhosis, but no statistically significant difference in terms of overall survival as these patients were being followed. When they tried to identify predictors that could help distinguish between those who had less favorable hazards of developing HCC and decompensation, they found, interestingly, that platelet counts greater than 100 conferred a similar risk of developing HCC and decompensation to compensated cirrhotics, and individuals with platelet counts less than 100 were at higher risk of developing these outcomes. So what we can glean from these findings is that among patients with Hep B cirrhosis who have achieved recompensation, those individuals with higher platelet counts, meaning a platelet count greater than 100,000, seem to demonstrate a more favorable prognosis that is similar to the compensated cirrhosis cohort. But otherwise, the rest remain at a higher risk of HCC with a hazard ratio of 3.38, and also a higher risk of incident decompensation at a hazard ratio of 1.5. So this concludes my presentation, and I'm happy to take any questions that you may have.
Excellent presentation, Qasim. In a short period of time, you covered a lot of important topic. So any questions from the audience? Altaf Saab, do you have, I know that Dr. Professor.
Thank you. Thank you, Qasim. Excellent selection of abstracts. I was also surprised, like you, about the dose of terlipressin used in the trial of vasopressin versus terlipressin. Well, if you want to give bolus, then at least 4 to 6 times a day, or it would be better to use infusion of terlipressin. So I think one has to take that with a pinch of salt, but a good attempt, it's a good study. At least it gives you a hint where we stand in terms of use of these agents in certain clinical situation. Again, the study of HBV compensated cirrhosis versus recompensation, it just highlights that we have to be very careful in dealing with recompensated patients, more aggressive surveillance, and because they are more likely to get HCC and decompensation, although there is no survival difference, but certainly in the day-to-day management of such patients, one has to be aware through this abstract that one has to be more aggressive in the follow-up of such patients. Thank you once again for an excellent presentation and good selection of abstracts. Thank you, Qasim.
Hey, Qasim.
I appreciate that.
Qasim, a question. What's your practice now after showing the data for primary prophylaxis for SPP? Because I know there's like more, and there's still a jury still out there based on this impressive randomized controlled trial. What is your clinical practice?
I'll be honest with you that even before the aseptic trials, I've started to move away from primary prophylaxis in the patients with a ascitic protein less than 1.5. Certainly individuals who've had SPP, there's no doubt that they need to be on antibiotic prophylaxis, but in the last few years, I have moved away from, especially as more and more data has come out with respect to multi-drug resistant organisms, and we're having more patients with acute and chronic liver failure. And again, the data a few years ago, the ASLDs, a group of young investigators, the Liver Fellow Network had, Jeremy Louis Saint had gone into all the literature and all the major trials, and he had identified numerous flaws in methodologies of the studies that were looking into primary prophylaxis. And almost consistently, a lot of these studies actually included patients who had SPP before, which kind of refutes the entire purpose of doing the study. And especially after I saw that that review, it kind of solidified my practice that for individuals, for primary prophylaxis, I've moved away from starting them on antibiotics because the concern for multi-drug resistant organisms and whether or not there is a great clinical benefit is now under question, especially with the aseptic trial.
Yeah, and I think the SGLT2 story is very interesting. I think that it's not ready for prime time, but what do you learn from it? And, is there any change in your practice with diabetics especially?
Yeah, I mean, I think we're in an age right now where, we're repurposing a lot of medications, whether it be SGLT2 inhibitors, whether they be GLP-1 receptor agonists. We're utilizing a lot of medications from our endocrinology colleagues that are conferring cardiac benefits, renal benefits, and so forth. And because a lot of our patients now have MASH, we're not just looking at the liver in a silo, but we want to improve their overall survival. And so we want their hearts to do better, their kidneys to do better. I do think that there is merit in recommending the use of SGLT2 inhibitors. And I think as a hepatologist in my practice, I've started to look at those things and see how I can improve the metabolic profiles of my patients and how they can benefit from some of these therapies and not just things like statins. But I am working with my family physicians and internists to, let them know that from a liver standpoint, I'm okay if they want to start a statin. I'm okay if they want to start a GLP-1 and an SGLT2 inhibitor. Understanding that there's definitely a hesitation by internists and family physicians in starting new meds in patients who have decompensated liver disease. In terms of whether I'd start it in patients with ascites now, I think I'd like to see more data, and not in an open label setting and in a multi-center setting in terms of SGLT2 inhibitors. And I know there's work being done on this. But I think it would be very important because we're kind of in a I'm in a practice, or I'm in a healthcare system where we're limited on resources and personnel, and we run a paracentesis clinic. So if we're able to even mitigate the number of patients who need large volume paracentesis and don't show up to emergency rooms just to get a paracentesis done, that would be really helpful for us as a single payer health network. So I do think there's merit in there, but more studies are needed. But I would welcome any medication that could help my patients come off of diuretics.
Okay. One last question, yeah.
For the SGLT2 inhibitor, I just had, this was another issue in Pakistan as well, the large volume paracentesis with the albumin as well. We can have probably start a multi-center trial here as well because it's relatively cheaper. And we can, I would love to have a collaboration with Qasim as well if we can have a trial here with a multi-center trial. Yeah. And one more comment, I would just like on telepressin because vasopressin is not officially available in Pakistan. It's baggage item, and I'm running the ICU here at JPMC where we come across this scarcity of availability of vasopressin, where we use telepressin as a vasopressor, as a second line, and we use in an infusion, similarly as that of the vasopressin, and we don't use the bolus doses. But I would like to look into the data for what the safety of the telepressin, because the question remains for the type 2 MI, which presents in these patients when we are using multiple vasopressors in these patients.
Excellent.
I mean, I think it's interesting because we have the opposite issue here in Canada, where we have vasopressin, but we don't have terlipressin. And so it was important to be able to see a comparative analysis in order to ensure, at least from our standpoint, that if we're using vasopressin as a substitute, is it really as effective? So at least, there are flaws in that study and that design even. But I think it was a good stepping stone so that's, other groups or even that group themselves can improve on that and potentially even do a blinded study with multiple centers. It would make more sense to compare an infusion to an infusion since there's already been trials in the HRS data, there's been trials in the ACLF data, that there is more benefit of a continuous infusion in terms of mitigating adverse effects at least. And with a signal in the ACLF data that it may even be a little bit more efficacious to use continuous terlipressin. So I'd like to see that as well. But it was good to be able to, unite areas where there may be availability of terlipressin but not vasopressin and vice versa.
Thank you, Qasim, so much for the amazing presentation and taking time for question and answer. Thank you. We'll love to see you in person at some point in Pakistan.
Thank you very much. Inshallah. Thank you all.
Okay, so we'll move on to our next topic and our very own Dr. Khalid Mumtaz, whose congratulations of being promoted to Professor of Medicine. He's a co-director of Living Donor Transplant at Ohio State University, and he will be the next session will be combining viral hepatitis and hepatocellular cancer. So take it over, Dr. Khalid Mumtaz.
Assalamu alaikum and good morning to all the participants in Pakistan. I believe that you can hear and see my presentation. Can you?
Not yet. We are working on it. Yeah, we can see your slides.
Just a minute.
Yeah, we can see you now, and we can see your screen, not the slides.
Okay, what about now?
Yeah, we can see your slides now. Thank you.
All right. So I want to thank the organizer of this program and all the participants, including Dr. Alam, Dr. Bilal Hamid, to allow me to present the ASLD 2025 debrief. The topics which are allotted to me are HCC and viral hepatitis. Before I go and talk about these topics, you can see this building. This is our new hospital tower of Ohio State University. I've been told that this is one of the largest hospital building in the United States. Its area is about 1.8 million square feet. It costed us about $2 billion, and it has a capacity of catering about 900 patients. So it's going to be a game enhancer in the central Ohio. and we are looking forward to move to this new building very soon. So I have selected about 5 abstract, and I looked into the novelty of these abstract, and I also looked into what could be the change in the practice of mine and the change in the practice of the hepatologist who I'm going to be sharing with today. So the theme of this debrief is I will start with a study on the HCC screening, and then there were a lot of papers about the role of the multidisciplinary liver tumor board in the HCC management. I'll look into the angle related to that, and then I will review a randomized controlled trial for the management of post-embolization syndrome in patients with the transarterial chemembolization. This is age of artificial intelligence. There were a lot of papers related to artificial intelligence and HCC prediction. I selected one of those papers as well. And then I will discuss a very interesting topic of role of the immune checkpoint inhibitor in downstaging HCC and post-liver transplant outcome. And if the time allows, I may also discuss outcome of the HCC in patients with MASLD, with Hep B and without Hep B and MASLD alone. So without further ado, this is the first abstract that I have selected. The title is Outcome of the Ultrasound LIRAD Visualization B in HCC Surveillance. We know that for the surveillance of HCC in high-risk individual, there is a recommendation to check the ultrasound every 6 months along with alpha-fetoprotein. The recent focus is on the ultrasound reporting system, what we call as the LIRADS ultrasound reporting system, which has 2 components. One emphasizes on the presence or absence of the lesion. The other one was about the visualization quality of the liver lesion. The consensus on the WIS-A and WIS-C is very clear about what is the next imaging modality. However, for the WIS-B, where there is moderate limitation, the consensus is still not clear. So this study authors studied the clinical outcome associated with the WIS-B in context of the HCC surveillance. So what they did in this study, they selected the patients at high risk for HCC, including cirrhosis or chronic Hep B with or without cirrhosis, who underwent an index ultrasound with WIS-B, which means moderate limitation of the ultrasonologist between March 2020 and August 2022. Radiology database was inquired, and all the patients with WIS-B ultrasound were analyzed. The data was procured from the electronic health record. The endpoint of the interest was interval imaging following index ultrasound scan, with focus on the imaging modality, subsequent visualization scores, and clinical outcomes. This is the demographic and the patient characteristic features. A total of 384 patients with the WIS-B ultrasound were selected. You can see that majority of the patients were from the Asian race, 57%. Majority of the patients, almost 60%, have hepatitis B as the cause of their liver disease, followed by MASLD. And majority of the patients were not cirrhotic, 61%. This is the flow diagram of the WIS-B patient, who were 384. Our group of interest is the US1, which is 347 patients. You can see that their interval imaging majority of the time was subsequent ultrasound at 3 months in 239 patients. Only 42 patients underwent cross-sectional imaging. And out of these 42, 2 patients have either LR4 or LRM or LR5 lesion. Rest of the patients have no lesion of remark. And about 1/4 of the patients have improvement in their WIS-B quality to WIS-A as well. The authors have discussed that among patients with the ultrasound LIRAD WIS-B negative ultrasound, one finding on surveillance ultrasound were unlikely to have HCC detected on the subsequent imaging. As I mentioned, 1/4 of the patients have improvement in their ultrasound quality from WIS-B to WIS-A. However, there are certain limitations of the study which the authors have identified as well. One of the main limitations was the fact that there were 60% of the patients without cirrhosis. So the authors concluded that follow-up multi-phase contrast-enhanced CT or MRI after a US1 WIS-B surveillance is unlikely to yield additional benefit. Consider repeat ultrasound for US1 and WIS-B at 3 months interval. Moving on to the next abstract, the title was Pattern of the Specialty Utilization in Multidisciplinary Management of HCC. It was an experience at 3 destination medical centers affiliated with the Mayo Clinic. What they have done is they have tried to find out the distribution of the specialty involvement, which means the role of the specialty, which was part of the liver tumor board, and what specialty was deriving the main management of these patients. These are the results of this study. They found that there were 6,051 patients with the HCC during the time period of study. Out of those, approximately 4,800 met inclusion criteria. They found that hepatology was the main deriver in the liver tumor board in 51% of the cases, followed by interventional radiology in 14% and medical oncology in 10% of the cases. They also found that interventional radiology was the initial HCC provider for 41% of the cases. Medical oncology took care of the treatment in 30% of the cases, followed by the HPB team, radiology, rad oncology, and the liver transplantation team in only 9% of the cases. IR was not just the responsible party for the first treatment, but they were also the part of the providing the treatment, the subsequent treatment as well. Among patients with the BCLC stage, which were 906, IR was most frequently the initial therapy provider for stages 0 and A, while medical oncology for stages B and C. The authors concluded that the study maps real-world multidisciplinary HCC care pathway. As the treatment options expand, structured tumor boards and shared decision making remain essential. Interventional radiology plays a central role across the care continuum, and the hepatology was critical for the assessment of the liver disease, and then further management and assessment for the transplant potential and post-intervention care as well. The authors have advised that the future work should examine how specialty involvement impacts outcomes such as survival, transplant eligibility, and the time to the treatment. Moving on to the third abstract, it was titled Artificial Intelligence in Predicting the Risk of HCC in MASLD, Development and Validation of a Predictive Model in 306 Patients. This study was from Brazil. We know that patients with the MASLD are increasingly recognized as being at risk for HCC. Early risk stratification is critical to optimize the surveillance strategies, yet conventional models remain limited. AI offers the potential to integrate diverse clinical and lab parameters, enhancing identification of individuals at high risk. The authors aim to evaluate the accuracy of an AI model based on the routine lab and clinical data in predicting the risk of developing HCC in the MASLD. They aim to create and validate a tool to support the risk stratification and facilitate early surveillance of high-risk individuals. They selected a retrospective cohort of patients, 306. Out of these, 129 with HCC were selected as cases, and 177 were selected as the control group. They include the clinical variable, laboratory variable. They include the non-invasive indices, neutrophil to lymphocyte ratio, FIB4, and AST-ALT ratio. They used the extreme gradient boosting AI algorithm was implemented, and the data set was randomly split into a training cohort of 80% and an internal validation cohort of 20% to develop and assess the model's performance. Here are the results. The extreme gradient boost based AI model demonstrated excellent discriminative performance with an OROC curve of 0.90 and sensitivity of 91% and specificity of 84%. The most influential predictors were creatinine, portal hypertension, neutrophil lymphocyte ratio, and LDL cholesterol. When they compared it with the other available predictive models, the only one which was closer was GALAD, which has a OROC of 0.92. However, it has a lower sensitivity of 82% as compared to almost 91% with the MESL HCC score of this proposed study. The authors concluded that the AI-driven model developed using widely available clinical and lab parameters demonstrated excellent performance in identifying MESL patients at high risk of developing HCC. By enabling early and cost-effective risk stratification, this tool may support targeted surveillance strategies and improve the clinical decision-making in real-world hepatology practice. The next study was an interesting one. This is what we see in our clinical practice in our patient post-transarterial chemoembolization. The title of this study was Efficacy of Dexamethasone versus N-acetylcysteine in Prevention of Post-Embolization Syndrome in HCC patients. Post-embolization syndrome is frequent and it is reported in 7 to 60% of the patients after the TACE procedure. The routine predictors of the post-embolization syndrome are large HCC, non-selective approach, dose of the chemo, and experience of the operator. The treatment mostly is supportive. In this study, the authors proposed a phase 3 randomized control, double-blind, double-dummy parallel group non-inferiority study. They compared dexamethasone versus NAC for the efficacy and safety in preventing post-embolization syndrome after TACE. They included the patients belonging to BCLC A and B without macrovascular invasion. This is the flow of the study. You can see that one of the group was given dexamethasone, the other group was given N-acetylcysteine. Dexamethasone was given in one dose of 8 milligram about an hour prior to the TACE procedure, and then they underwent TACE procedure, and after that followed for various outcomes. This is the flow diagram. In the final analysis, they were able to find 40 patients in the dexamethasone group and 38 patients in the N-acetylcysteine group. The outcomes studied were composite post-embolization syndrome, including abdominal pain, nausea, vomiting, transaminitis, and fever, and all of these individual symptoms as well. They also looked into the liver decompensation and anaphylactoid reactions. Here are the results. Majority of the patients belong to CTP A and BCLC B class. They reported that post-embolization incidence was non-inferior between the two groups, 13% as compared to 17% in the NAC group. Here are further results. They looked into the impact of the dexamethasone versus NAC on the post-embolization syndrome and did not find any significant difference in the composite outcome. However, the individual outcomes were improved. In the dexamethasone group, fever reduction was 52% as compared to 28% in the NAC group. Pain reduction was also significantly better in the dexamethasone group, 87% versus 53% in the NAC group. Post-ACE liver decompensation was remarkably low in the dexamethasone group as compared to the NAC, and the anaphylactoid reaction was seen in about 18% of the patients who received NAC. Furthermore, they see that the disease was stable in dexamethasone group, as well as disease progression was lower in the dexamethasone group. However, it did not reach statistical significance. They also looked into the multivariable analysis for the prediction of the post-embolization syndrome after TACE. Serum ALT was one of the predictor. Among the predictors of the post-TACE liver decompensation, bilirubin and dosage of the chemotherapy stand out as the independent predictors. Here are the conclusion of the study. The post-embolization syndrome incidence was non-inferior between the two groups. However, at 48 hours post-TACE, dexamethasone was associated with a significant reduction in fever, pain, and liver decompensation. Additionally, the anaphylactoid reaction and other adverse events occurred exclusively in the NAC group. Moving on to the next paper, this is an interesting paper, and it is one of the most exclusive, I would say. The title was Pre-Liver Transplant Immune Checkpoint Inhibitors and Post-Liver Transplant Outcomes in 408 HCC Patients. It was a global retrospective study from the LIFT HCC Consortium. Our hospital, Ohio State University, also contributed a few patients to this very exclusive study. We know that immune checkpoint inhibitors have revolutionized the treatment for advanced HCC. Here I have shown two of the studies comparing the impact of two of the immune checkpoint inhibitors along with the TACE compared to the TACE alone, and they found that the combination of the immune checkpoint with TACE is helpful in improving the progression-free survival. The second study on my right, which is the Emerald study, which studied the impact of using Lenva with Pembro plus TACE and compared with the TACE alone, shown also progression-free survival better in the combination group as compared to the TACE alone. So based upon these two trials, there's a potential role of immune checkpoint inhibitor as a downstaging therapy for the liver transplantation. This was the basis of collecting the data for the LIFT HCC consortium. The aim of this consortium was to estimate the long-term overall survival, recurrence, rejection, to identify the predictors of the outcomes, to compare the outcome between patients downstaged with the immune checkpoint inhibitor and those always within the liver transplant criteria. As I mentioned, that this was a consortium called as the LIFT HCC. It was the first global collaboration including Asia Pacific, North American, South American, and European centers. And the authors have invited all the high volume United States liver transplant centers performing more than 100 liver transplantation in the year 2024. There were multiple data points collected, including the longitudinal measurement of the tumor burden and the alpha-fetoprotein, ICI cycle type, and washout period. Various outcomes were studied, including overall survival, rejection, and HCC recurrence. Coming to the result of this study, there were a total of 408 patients from 60 centers. Majority of the patients were contributed by the Chinese centers, 60%, followed by the US centers, 26%. The mean age of the patient was 55. At ICI start, 75% of the patient have a CTPA cirrhosis. Maximum tumor diameter was 5.5 centimeter. Median alpha-fetoprotein was 53. Majority of the patients belonged to BCLC B and C. 23% of the patients were within the Milan criteria. 91% of the patients underwent loco-regional therapy, and 57% of them received the loco-regional therapy before starting the immune checkpoint inhibitors. Majority of the patients have undergone deceased donor liver transplantation. Various types of the immunotherapy were used, including Nivo and Pembro is in 69% of the patient, Atezo in 25%, Atezo and Beva combination in 21%. So you can see that there isn't any uniformity in the use of the different immunotherapy. One of the most important variable was ICI washout, which was a median of 73 days. These are the different outcomes which were studied: the tumor burden, alpha-fetoprotein. The tumor burden changes from ICI start to the liver transplantation. There was a reduction in the tumor size, there was a reduction in the tumor number, and there was an improvement in the Milan criteria from 23% to 43%. Alpha-fetoprotein was also improved. Outcomes after the median follow-up of 21.2 months. Allograft rejection was seen in 19%, HCC recurrence in 26%, and death was reported in 21% of the patient. These are the Kaplan-Meier curve for the HCC within Milan criteria at liver transplantation, and it is showing that it is associated with lower risk of recurrence and prolonged improvement. It is also on my right side, the curve is showing that lower alpha-fetoprotein at liver transplantation is associated with a lower risk of recurrence and prolonged overall survival. These tables are basically showing that patients who were within Milan criteria and alpha-fetoprotein of less than 20 have a better overall survival. 91% 1-year survival, 3-year survival of 84%, and 5-year survival of 84.6%. Similarly, the recurrence-free survival was also best in the patients who were able to achieve within Milan criteria and alpha-fetoprotein of less than 20. The other predictors of allograft rejection were older age. So older age has a safety factor for the allograft rejection. Longer ICI washout beyond 30 days has a protective effect against the allograft rejection. Similarly, the HCC recurrence was dependent on the log of the alpha-fetoprotein at the time of liver transplantation, and also upon the criteria of the Milan. The overall survival predictors were HCC recurrence and severe rejection. These graphs are again endorsing what I have just alluded to. The recurrence predicts shorter overall survival, no recurrence, better survival as compared to recurrence. And then severe rejection predicts shorter overall survival. However, the survival in patients who have mild to moderate rejection was equal to those who do not have any rejection. There were a lot of limitations of this study. First of all, it was a retrospective design study. There was no control group. The median follow-up was shorter, 21.2 months, predominantly Asian population of 60%, and very limited safety factors were checked. The only factor which was checked was rejection. The other side effect related to the use of the immune checkpoint inhibitors were not looked into. However, it was one of the first trial which has looked into a lot of important aspects. The clinical takeaway of this trial are pre-liver transplant immune checkpoint inhibitors are feasible and overall safe. Severe rejection is rare but worsen the overall survival. Traditional selection criteria, including alpha-fetoprotein, tumor burden, and within Milan criteria predictive of the outcome. The status at the liver transplant is stronger predictor than at the ICI start. And the most important message, which to me is something to consider going ahead in my practice, is longer ICI washout beyond 30 days is something that needs to be practiced when you are selecting the patient who are on immune checkpoint inhibitor and undergoing liver transplantation. The future direction could be to do prospective studies with the control group, define ideal locoregional therapies with timing within immune checkpoint inhibitors, prediction of the responders and the down staging candidates. There is one more paper, one more abstract, but because of the lack of time, I'm going to pass it on and go to my concluding slide. So these are the final take home out of the 5 papers that I have discussed today. In the first paper, I discussed about the ultrasound modality based upon the LIRAD. When you have VIS-B report based upon the abstract, you can go ahead and repeat an ultrasound in 3 months. There is a 1/4 chance that the VIS-B may convert to VIS-A, and based upon that, you can continue with the HCC screening. In the second paper, I reviewed the multidisciplinary liver tumor board from the Mayo Clinic. It has given us a message that it is very important to keep assessing the HCC management and acknowledge the liver tumor board teams which are involved in the care of these patients. Then I showed you an AI-based model for the prediction of the HCC. Our model, the model of this abstract, which was extreme gradient boost-based AI model, suggested a very good OROC score, sensitivity, and specificity for the prediction of HCC. In my fourth paper, I compared the use of dexamethasone with NAC and found that dexamethasone is helpful in reducing the post-embolization syndrome and liver decompensation at 48 hours. In my last abstract, I talked to you guys about the use of the pre-liver transplant immune checkpoint inhibitor, and the abstract showed that it is feasible and overall safe. Longer ICI washout beyond 30 days is advised. Thank you, and these abstracts are open for further discussion.
Thank you so much, Dr. Khalid Mumtaz. Any questions from the audience? Okay, we have Dr. Asif and then Dr. Hassan Nabi Tayyib. Go ahead.
Dr. Khalid, nice presentation. One question regarding the ICI for HCC. So the mention is like ICI should be like they have the longer washout period of about 73 days here, right? So setting like Pakistan here, like where the mainly the transplant is done in the living donor transplant, right? So at what time they need to be stopped here, right?
So Khalid, I don't know whether you you heard the question, right?
I did hear the question, yeah. So the study that I have showed you has suggested that the median time to stopping the ICI was 70 days. However, the analysis has suggested that any time beyond 30 days is associated with a better outcome in terms of lesser allograft rejection and improvement in the overall mortality as well. So I believe that in the context of the live donor liver transplantation, the surgery is most of the time a scheduled surgery. And particularly for the HCC, there is no urgency in, jumping on the surgery. So in the context of the live donor liver transplantation, things are better in control. So based upon this paper, I think the practice would suggest to at least wait for 30 days of washout. The more washout days beyond 30 days, the less are the chances of any harmful effect of the immune checkpoint inhibitors.
Yeah, I think in our center, we do 90 days till 3 months for living donor transplant. We are changing for a diseased donor who have more, so minimum is a month for the diseased donor. We stop it because we can't predict when the offer will come in. Most of the time, they still end up waiting for more than 2 months. For the living donor, we're still using 3 months mark. Dr. Hazan Nabi Tayyib.
Khalid, excellent presentation, excellent selection of the abstracts. I'm also of the view that 90 days is the right time for living-related donation. As regards the AI-based HC detection and comparison with the GALET, since specificity with GALET is little more as compared to the AI-based HC detection or prediction, did they check against the other scores as well, like HES version 2 or 3?
As you can see in the abstract that I have presented, they have checked it against the non-invasive markers. The markers based upon the APRI, ALT, AST scores. I'm not sure what scores are you talking about, Dr. Tayyib?
The GALET sensitivity is not all that different, 89% against 91%. So was it statistically significant? And then another prediction tool that we use in terms of scoring system, HES version 2, did they use that as well? Did they check it against that one as well?
No, they did not. If you look at, I'm projecting the slide again. So here is that slide. I hope you can see it.
So they've checked it against AMAP, they've checked it against GALET.
Yeah, they didn't check it.
And against GALET, it's closest against the GALET, 82% against 90 in the sensitivity. But GALET is most sensitive, 89, more specific, 89 against 84.3.
Correct, yeah, you're right. So they've not checked against the one that you are talking about. But when they checked again GALET, it is very close to the GALET. And you're right, GALET has better specificity, and the score which they proposed has better sensitivity.
Okay. Dr. Amjad Salamat, do you have a question?
Just wondering, with the dexamethasone and the NAC, N-acetylcysteine, so they used a single dose. Is that, if I'm correct, they used a single pre-op dexamethasone dose? But usually,
that's true.
In clinical practice, usually people actually continue dexamethasone for quite some, at least 3-4 doses, something like that. I don't know if that would make a difference and would be a wider difference between NAC and DEXA. So
you know that in our clinical practice at Ohio State University and the places where I have worked, we do not use NAC or dexamethasone in this group of patients. And as you can see, there is prevalence of post-embolization syndrome is very.
I think Dr. Khalid Mumtaz got muted. Yeah, I think we don't also use anything preemptively or before the chemoembolization. So I think that is something that we have to, but you're right that when they have used it, it's like multiple doses, not one. So that is something. And I think the one thing before we move down, this, Khalid, can you hear us about the ultrasound thing? One thing that Dr. Ghazan Nabi Tayyib has an excellent talk yesterday about the HCC in the resource limited setting. In the US, the Radiology Society, hepatologists, everyone is working together on the guidelines. And I think that is, some work has been happening from this platform. I think that maybe something about the HCC surveillance, about the ultrasound, because the quality of ultrasound is all over the place and how they read it would be something. Is there some work going on in Pakistan regarding the radiology societies about the HCC? Anything in that regard? Does anyone has any input? Dr. Altaf Alam? Nothing. I think that. And is there an active radiology society? Must be. I think there must be, some, I think Dr. Ghazan Nabi Tayyib, I think would be a good thing to have it, a discussion in that regard from them to have it. Because I get like someone, go ahead.
Yeah, I think there is, I heard, because we had a radiologist, we invited him for an HCC talk, so they're actually looking into that and they're trying to formulate some guidelines on that, but and nothing has come up as yet, but they are making an attempt. But I think what needs to be emphasizes that most of the time when we're discussing radiology, it is actually the cirrhotic and the non-cirrhotic livers, because it's very difficult in the non-cirrhotic livers, and plus the size of the tumor. So when we say, usually we discuss overall sensitivity and specificity of the ultrasound in detecting these lesions. But if you have a smaller lesion, the one that really matter actually for transplant and curative treatment, and then you have an ultrasound in a cirrhotic liver, the actual sensitivity specificity is not very high. So as you move to the larger tumors, maybe the sensitivity improves, and when we discuss the overall sensitivity specificity, because on average, it actually over-represents the picture. I mean, it gives a rosier picture than it actually is. Because we run work in a transplant unit, so what we do is in these high-risk patients, we actually do an abbreviated MRI, and we are sometimes surprised because the ultrasound, as you said, the quality and whatever, and we find many tumors which are not picked up with the ultrasound.
Okay, excellent. Thank you, Dr. Khalid Mumtaz, for the excellent presentation, and we'll give a round of applause for Dr. Khalid Mumtaz. And next one is our another rising star, Dr. Sobia Laik. She's at Cleveland Clinic and has been very influential in taking over their MASLD program and obesity. Have some very interesting investigator-initiated studies that's been going on, and she will be presenting on updates on MASLD. So please welcome Dr. Sobia Laik.
Good morning, everyone. I apologize, I'm just trying to share my screen appropriately. Right. Good morning, everyone. Assalamu alaikum. Thank you, Dr. Hamid, for giving us the opportunity to present today. So what we're really going to be talking about now is metabolic dysfunction associated steatotic liver disease. And really, as we kind of review some of these high-yield abstracts, we're going to try to go through a theme really kind of initially focusing on where we stand from a natural history standpoint, some of the diagnostic challenges we're still having in terms of identifying high-risk patients, and kind of where we're heading in the therapeutic pipeline for fibrotic MASH patients, and then eventually some of the nuances of navigating care for patients, particularly with MASH-related cirrhosis. So with that, the first abstract that I really wanted to kind of highlight was a natural history study looking really at the evolving changes in terms of the comorbidity burden that we see in steatotic liver disease. So historically, what we've seen is predominantly that cardiovascular disease has been the leading cause of morbidity and mortality in these patients. However, with the increasing realization of cardiovascular disease as the leading etiology of death in the United States and the increased awareness and screening for it, what we're now seeing from this US National Vital Statistics data from 2010 to 2024 is that MASL-related mortality has tripled from 1.01 to 3.12 per 100,000 years of patients. However, cardiovascular disease has predominantly declined, and what we've really seen is a rise in obesity-related malignancy in these patients. Whether that's predominantly driven by hepatocellular carcinoma or metabolic-related other malignancies in the GI tract or gynecological, they didn't really parse out those details specifically, but that's a very interesting trend and really kind of emphasizes the fact that we should be doing a better job in terms of cancer screening in these patients. Next, we're going to talk a little bit about kind of the diagnostic dilemmas that we face when we're trying to identify high-risk patients. So this abstract titled Enhancing Steatotic Liver Disease Detection via Opportunistic Screening really focuses on using everyday diagnostic modalities that we have, for example, routine CAT scans that we might get for various different indications, and using those as an opportunity to see if we can maybe case identify MASLD patients better. And so what the group from Stanford really did was that they evaluated whether deep learning could enhance recognition of steatotic liver disease using routine CAT scans. So they retrospectively analyzed over 1,800 contrast-enhanced CTs that they had in their system using an AI tool called Comp2Comp. And what the algorithm really was able to detect was that upwards of 28% of scans that were done for patients identified patients with steatotic liver disease, which was significantly higher that was actually reported by radiologists, which was at around 12%, and significantly higher than what was picked up by ICD coding. ICD coding is a form of diagnostic coding that is pretty common in the United States in diagnosing or labeling patients with a certain diagnosis in their electronic health record system. And so really the clinical takeaway from this is that if we're able to validate this in a systematic manner, it could really become a very good system whereby we have automated risk alerts within our electronic medical record system, improving awareness at a significantly larger scale. Next, this abstract really kind of caught my eye because it really speaks about how we can optimize current screening modalities that we have, particularly in the way of vibration-controlled transient elastography, and optimize that to better improve our rates of identifying at-risk MASH patients, which is particularly patients with MASH with stage 2 or stage 3 fibrosis, which are the patients who we want to identify to link to therapy. And so what this group from China really looked at was using radiomics within vibration-controlled transient elastography for non-invasive enhancement of hepatic fibrosis in MASH. So they took about 163 biopsy-proven MASLD patients and analyzed that group and specifically applied radiomics to the extracted vibration-controlled transient elastographies that they had. And then they linked that with certain clinical parameters as well. And so they ended up developing this model that they call the ARLA model, which used the patient's AST, their radiomics R-score, liver stiffness measurement, and then their age. And the model ended up performing pretty well with a AU-ROC of about 0.86 to 0.87, which is within the good to excellent category, and significantly outperforming a lot of the current non-invasive tests that we have in our current guidelines, whether that be the FAST score, FIB-4, NAFL fibrosis score, AGILE-3+, or AGILE-4. And the other thing to note is that the they actually then did a sequential approach. So what's really kind of recommended in a lot of the guidelines from ASLD, EASL, and some of the endocrine societies as well, is to kind of use this sequential approach of doing the FIB-4 score first, and then followed by VCTE liver stiffness to narrow down in identifying high-risk patients. And so when they did the FIB-4 followed by the ARLA, what they found was that they had a significantly reduced gray zone. So their classification rate of identifying these patients was significantly higher, performing way better than the other available NITs. And so really kind of just becomes a stronger tool in our armor to non-invasively identify patients as we move further and further away from liver biopsies. Next, we're going to move on to now a little bit into the therapeutic area. So in 2024 was kind of a landmark year within the MASH space because we had the first pharmacotherapy agent that got FDA approval in the United States for patients with non-cirrhotic MASH with stage 2 to stage 3 fibrosis. And so as this medication is now becoming more and more, inculcated into clinical practice, a critical question that then arises is how do you identify treatment responders versus non-responders? And what this really highlights is a really big challenge that we're facing as more and more MASH therapeutics become available, which is realizing that not every patient is going to respond to every pharmacotherapy agent, And how do you kind of almost devise this precision medicine model whereby you link the appropriate patient with the appropriate metabolic profile to the correct treatment strategy? And so what they really looked at in this real-world cohort study was looking at everyday available tools that we had to see if there was a mechanism through which we could early identify responders versus non-responders. And so what they saw was that using the vibration-controlled transient elastography CAP score, which is the steatosis assessment, and the FAST score, and an improvement in that, even as soon as 3 months, was indicative of a patient that was a likely responder to resmetirom. And then if you follow that along for another 6 months, then you saw the CAP score, FAST, and the ALT improve as well. And we know that the transaminases, particularly ALT, do tend to lag because resmetirom does, cause a mild transient elevation in transaminases in the first 8 to 12 months, which then starts subsiding. So really kind of a good mechanism to start getting some kind of early signals to see which patients will respond or may actually need to have treatment adjustments or switch to a different kind of treatment modality. So next, we're then going to talk about semaglutide, which was the second medication that received FDA approval just fairly recently, in fact, in October of 2025 to use for MASH with stage 2 and stage 3 fibrosis. And so as the ESSENCE trial came out, one of the biggest questions that it kind of raised was, is the effect of semaglutide that we're seeing in terms of the histological improvement in MASH, whether that was MASH resolution or fibrosis improvement, was this largely being mediated through weight loss? Or was there a medication or drug-specific effect independent of weight loss as well that was allowing for disease improvement to happen? And so this was, in fact, a secondary analysis of the phase 3 ESSENCE trial, where they tried to look at weight-dependent and weight-independent effects of semaglutide amongst the participants. So they took the 800 randomized patients from ESSENCE, and they looked at the interaction between clinical outcomes. So, reduction in your transaminases, particularly your ALT, histological response, liver stiffness, and then correlated that to weight change. And what they did see that there was a significant weight-independent effect amongst all these parameters, which was independent of weight loss. However, in patients who did achieve, kind of the goal weight loss, you did see a higher rate of MASH resolution. So in patients who were hitting that 10% total body weight loss target, MASH resolution was higher from 48% to 72%, and fibrosis improvement also improved from 27 to 42%. And so really kind of the takeaway from this becomes that semaglutide does seem to work through a dual mechanism, both through its direct hepatic benefits and then the additional impact that it has in terms of improving the patient's cardiometabolic profile, just really kind of emphasizing its disease-modifying potential. All right, next we're going to switch gears a little bit towards now looking at patients with cirrhosis. And so really kind of the takeaway as we talk about this one is how do we determine if our patients with fibrotic MASH, what is their risk in terms of developing liver-related events or what we call major adverse liver outcomes. So in this abstract titled Real-World Evidence of Liver Decompensation or Transplantation Events in Patients with Compensated MASH in the United States, they essentially did a descriptive analysis of 4 large US claims databases. And so these are national databases that are maintained between either the US government or pharmaceutical companies, namely MarketScan, HealthVerity, Optum Clinical Informatics, Datamart, and IQVIA Pharmametrics databases. And they evaluated upwards of 140,000 patients between 2007 to 2022, really looking at the time to decompensation or liver transplantation. And what they saw was actually a cumulative 6-year incidence of decompensation or need for liver transplant was consistently being very high across all the data sets. And this was upwards of 24 to 27%, which is way higher than what's been reported in a lot of the clinical trials. And really kind of begs the question if, in a real world setting compared to what we see in clinical trials, does the heterogeneity of the patients, the differences in the metabolic burden, and the differences in the healthcare that they receive, is that a better representation of the risk that these patients carry? And so the clinical takeaway for me as a practicing hepatologist really is realizing that my patients who are coming in with compensated MASH cirrhosis are a very high-risk phenotype, and that almost 1 in 4 patients that I'm taking care of are going to progress to either decompensating or needing a liver transplant within 6 years. And what this really then does is has significant implications in terms of strategies that you implement for decompensation prophylaxis, how aggressive do we need to be with our surveillance strategies, and then how do we make assumptions regarding the natural history, not just for the clinical care that we need to provide, but also future trials that we may be designing for therapeutics, particularly targeting MASH cirrhosis patients. Next, I wanted to highlight another abstract, and this was a multi-center study out of Canada, and the abstract really kind of focuses on patients with MASLD that tend to actually decompensate at a lower hepatic venous pressure gradient threshold. And this was, to me, I think, a very striking abstract and something that, again, is very clinical practice changing, because what they did within this study is that they retrospectively evaluated about 409 patients and evaluated their hepatic venous pressure gradient thresholds for predicting decompensation and liver-related events in compensated advanced chronic liver disease patients. And they had about 1/3 of the patients with MASH. And so typically what they saw was that the traditional thresholds that we used for predicting decompensations actually very poorly performed in the MASH cohort. So the standard, clinically significant portal hypertension cutoff that we had of an HVPG of around 10 to 11 did really poorly in MASH patients in predicting decompensation, and that in fact, these patients were decompensating at a lower, pressure gradient of around 6. And again, similarly, in terms of developing late decompensation, we were seeing it at a lower pressure gradient. And so, again, this just begs the question, should we have individualized recommendations or guidance for MASH patients? Next, just changing gears a little bit, now kind of focusing on potentially what are some of the therapeutic targets that we have then for patients who have established MASH cirrhosis, who might in fact be developing clinically significant portal hypertension. Like, what can we do for this patient group in preventing, liver-related events? And so this study focused on efruxifermin, which is one of the FGF21 drugs that are being developed for treatment of not just fibrotic MASH, but also MASH-related cirrhosis. And what they did was they did a secondary analysis of the SYMMETRY phase 2b trial. And they used routine non-invasive tests to assess the drug's mechanism in terms of its impact on clinically significant portal hypertension and hepatic decompensation risk. And the outcomes that they assessed were, one, the Baveno 7 criteria for clinically significant portal hypertension, and then secondarily, they looked at what proportion of patients achieved a 20% reduction in AGIL4, again, another non-invasive predictor of liver-related events. And what they saw was a pretty impressive dose-dependent response. So in terms of improvement in clinically significant portal hypertension, in patients who received the 28 milligram dose had a reduction of clinically significant portal hypertension in almost 18% of patients, and 13% of patients in the group that got the 50 milligram dose, which was clinically significant, compared to 29% with placebo. And very similar results in, the AGIL4 group too. And so the question becomes really kind of what is our takeaway? And I think our takeaway really from this is that we have very encouraging results from the SYMMETRY trial in terms of the histological fibrosis improvement when efruxifermin was given to MASH cirrhosis patients. But again, this study also just highlights its disease-modifying potential in terms of even taking patients who've already developed clinically significant portal hypertension and reducing their decompensating risk. So, right. And then this is in fact, now the last abstract that I wanted to speak to. And this abstract really kind of looked at the risk of first acute variceal bleed in mast cell decompensated advanced chronic liver disease patients who were in fact receiving carvedilol-based primary prophylaxis already. And so what they did is that they took patients who had decompensated cirrhosis, so these are your Child-Pugh B and C, who already had a prior variceal bleed and had evidence of high risk, or high risk stigmata of varices, who'd been initiated. They actually had two groups, one who previously decompensated and the other group that had high-risk varices who was placed on carvedilol for primary prophylaxis. And the significant finding from this abstract was that the patients, particularly the group that had MASH cirrhosis, had a significantly higher rate of developing an acute variceal bleed despite receiving carvedilol as primary prophylaxis compared to patients who had viral liver diseases. And so their hypothesis really was that in patients with MASH, there is such a profound insulin resistance and altered splanchnic vasoregulation that it almost blunts the hemodynamic response that we would expect to get from non-selective beta blockers. And so the clinical takeaway from this then becomes, are our current portal hypertension prophylaxis strategies not as effective for MASH cirrhosis patients as they may be for, say, viral etiologies or alcohol-related? And so do we need more personalized approaches, or do we need to consider earlier consideration of alternate therapies? For example, consideration for TIPS in a patient who's coming in with repeated large varices that we're not able to endoscopically manage. And that is all I have, everyone. I just wanted to give a shout out and thank you to all the investigators, collaborators, and clinical teams who are advancing, the care of MASLD and MASH, and all the investigators who submitted these high-yield abstracts for AASLD for us to review.
Excellent presentation, Sobia. It's hard to cover all the MASLD topic in such a short period of time. I think is there any question from the audience? I have One, to start with, the last abstract, Sobia, you presented, it was also, very interesting, and I was also thinking about our practice because we were using carvedilol, and then the thought with the Pavino that you don't need to have a repeat endoscopy for primary prophylaxis, but I have seen patients coming in. So have you changed your practice about, like, for primary prophylaxis, are you doing endoscopies on those patients and consider for band ligation in this selected? I know it just came up, or is there any change in your practice based on that?
No, that's a great question. And I think really what Baveno did for a lot of people is give them almost, I would say, an air of caution that, like, if you have a patient who has a certain liver stiffness and platelet threshold, we don't even need to do a screening endoscopy. And I think seeing the data around MASH cirrhosis patients, one, decompensating at lower HVPG thresholds, and that they are unlikely to also be non-responders to carvedilol, I think in patients, particularly who have, and I think, I'll be fair, I think I've individualized it quite a bit. So in patients where I feel like their cardiometabolic disease is very uncontrolled, so that may be someone who has ongoing class 3 obesity, is an insulin-dependent diabetic. I will have a much lower threshold to scope, band, and if not responding, consider for tips. But I think, in someone who's lean, cardiometabolically controlled, you'd almost think that the insulin resistance component's almost controlled, which is driving a lot of this, that you may not need to be as aggressive. And then there's also nuances in them being able to tolerate the carvedilol because they're typically on other antihypertensives as well. So I'd say it's a pretty, individualized approach.
Perfect, thank
but
you.
Definitely, not just sticking to the Baveno anymore.
Okay, I think we have few questions, Dr. Amjad Salamat.
Yeah, so just a quick question. Did this surmise on the reason for low pressure decompensation in these patients? What's the other factors leading to this sort of a thing? And is there a correlation between, you mentioned about Baveno 7, so is there a correlation between elastography and picking up these patients earlier for whatever we want to do?
That's such an interesting question. And I'll be honest, I'm very curious to see when the manuscript comes out because they didn't give those details. I think as far as liver stiffness measurement is concerned, again, I think there's a lot of emerging data coming. A lot of that's actually going to be submitted to EASL regarding the poor diagnostic performance of VCTE-based LSM in using Baveno-based thresholds in MASH patients. So traditionally, we'll say, okay, well, if a patient has a liver stiffness of greater than 25, they have a high risk of decompensation. But what we're realizing is that the LSM in a MASH cirrhosis patient is often inflated because of hepatic steatosis, abdominal adiposity, and so that LSM of 25-30 may actually not be truly reflective of a high-risk HVPG threshold. So I think as more data emerges, and there's a couple of different, scores that have recently come out. I think one is the Anticipate MASH score, and that paper was just published, I believe, in Gastroenterology, where they're realizing that for MASH patients specifically, we may need to have etiology-specific thresholds, taking into account their metabolic heterogeneity that impacts NITs.
Okay.
So,
Go ahead.
One more question. So this is regarding the liver fibroscan, the post-liver transplant setting, like in the de novo MASH. Is there any different cutoff or different CAP score, different fibrosis score? Because we are seeing a lot of post-transplant patients now with the MASH, with a de novo MASH. So the CAP score and the fibrosis score, they are different or they are like the same?
I mean, I'm going to admit that that's actually one of my areas of research right now. And I think recurrent and de novo MASH is so interesting. And it's, I think a lot of different centers have tried to use FibroScan or vibration controlled transient elastography to, accurately predict onset and then progression, whether that be recurrent or de novo MASH. And what you pretty quickly realize is how limited FibroScan is in terms of its performance, right? And so if you have, and I think from a CAP score perspective, you might get decent values, but the liver stiffness is often going to be often going to be inflated. And so we've seen pretty poor correlation between the measurements that we get from a FibroScan versus what we will get when we actually assess histology or do a liver biopsy. And so what you have to really keep in mind is that post-surgical anatomy where these patients have developed, either ischemic cholangiopathy-related biliary strictures, or they've had hepatic artery thrombosis and various interventions, all of that will impact the stiffness measurement that you get. So I think it's a good screening tool in identifying patients who might have developed recurrent or de novo MASLD, but it unequivocally needs a tertiary modality, whether that be MR elastography or histology right now, to definitively diagnose and then also stage. Because the correlation between the NIT and histology is extremely poor.
Okay, 2 more questions. I think Zishan and Dr. Khayatun Nabi Tabiyat.
One comment about the recent question of the transient elastography, because in transient elastography, we generally don't see the anatomy of the grayscale image of the liver, but the shear wave elastography may show a better results when we are looking into these altered anatomy patients. So that is again food for thought for those who are working in this area for post-transplant patients. The question regarding the beta blockers as a primary prophylaxis in this, most of these MASLD patients are generally metabolic dysfunction and diabetic and hypertensive. So it would be interesting to look into the dosage they have used and their blood pressure controls as well, because they have got systemic hypertension as well, and these patients generally are multiple antihypertensive as well. So that may be the factor which may have contributed failure of beta blocker prophylaxis in these patients.
Excellent. Thank you. Dr. Hasan Ravi.
Regarding 2 papers, two abstracts that you have selected, one with the HVPG and its correlation with the early decomp. People tend to bleed even when there's an effective dose of carvedilol. They appear to be a bit contradictory to each other, because we also have the impression that people who are suffering from MASH, they tend to have varices early, and they tend to have varices of high grade. And most of the time gastric varices, and they tend to bleed and bleed heavily. So is it either because of apoptosis and leading to early decompensation and nothing to do with the fibrosis? Is it because of that? And when we come down to the beta blocker, in most of the cases, we are managing the cases quite aggressively with antilipids and ARB along with. I don't seem to have a problem with a combination of this ARB beta.
Oh, thank you for your question. I think that there's just so many new validated. And so I kind of look at it as when these abstracts come through, what we're getting is a clinical signal. And so the question then becomes, is this gonna apply to a larger population? And then you kind of get into the mechanistic study. So I'd be very curious to look at this data myself. Now, in regards to patients bleeding when they're despite being placed on carvedilol, I think, again, you kind of have to look at the patient population we're looking at. And I think one of the things you quickly realize is that not all MASH patients behave the same. From a South Asian background who predominantly has abdominal adiposity and is maybe pre-diabetic. So I think this is an area where maybe we do need to get a little bit granular and look at really the impact of the metabolic comorbidities and how they're driving decompensation risk. Because what we do know definitively is that when we do get control of that, whether that is through metabolic or bariatric surgery, or whether that's through these incretins that we have coming in, between semaglutide and tirzepatide, which is when you definitively address the patient's diabetes and obesity, decompensation risk significantly drops. And so the question is, does that carry a significantly higher weight than the benefit that you might get from putting a patient on carvedilol?
Thank you so
So I
much,
think that
Sobia, for an excellent presentation. Give a please round of applause to Sobia. And I hope, so last but not the least, our last presentation today is Dr. Sajid Jalil. Many of you have seen him in some of the presentations. He was at PSH, he's at Stanford University, and his topic is autoimmune hepatitis and BBC. And at the end of the talk, I do want, beside that table, any other table to ask questions also. So,
Dr. Bilal Hamid, and this has been a very well-organized conference so far. And I want to congratulate the previous three speakers for doing a great job. They've set the bar very high. So I'll go ahead and get started. The topic I was given was autoimmune and primary biliary cholangitis updates from WASLD 2025. So first I'll start with primary biliary cholangitis. This is a abstract that looked at serum IgM levels, whether it has any association with prognosis in PBC patients. So elevated serum IgM levels are frequently observed in patients with PBC, and there have been very few studies examining whether there's any association. So this study from Japan looked at, this is a retrospective analysis. They looked at 427 patients with PBC, and out of those, 273 of the patients had liver biopsy, 154 did not. And they looked at association of serum IgM levels and liver-related events. The liver-related events were defined as occurrence of ascites, varices, hepatic encephalopathy, or hepatocellular carcinoma. And this is the results. So they divided the group into two cohorts, those with elevated serum IgM levels and those with normal IgM levels. The mean age was 58, and there were more male in the elevated IgM levels. The other parameters like biochemical AST, ALT, alpha, gamma GT, they were higher in the elevated IgM level cohort. And on the right, you can see the results. The top graph shows that patients who had high serum IgM levels had higher incidence of liver-related events. And even in the bottom two graphs, even in early clinical and pathologically early disease, there was higher incidence of liver-related events. So the conclusion was elevated serum IgM levels can be an independent predictor of liver-related events in primary biliary cholangitis, even in patients with clinical and pathological early disease. Next abstract examines the clinical paradox. In PBC patients, we see hyperlipidemia frequently. And the traditional teaching or assumption has been that this is benign hyperlipidemia and that it is not associated with cardiovascular disease. However, recent studies have questioned this assumption. And to address this, this is a multi-center retrospective cohort study where they looked at the impact of hyperlipidemia on cardiovascular and liver-related outcomes in PBC. So they used the TriNetX database, and patients were divided into two cohorts, those with hyperlipidemia and PBC and those without. They did propensity score matching. The primary outcomes were major adverse cardiovascular events, secondary outcomes, liver-related complications. These are the study results. The all-cause mortality of PBC patients were low, as well as liver-related events such as ascites, hepatic encephalopathy, SBP, and variceal bleeding were low. But the risk of cardiovascular and metabolic disorders were higher in those patients with hyperlipidemia. So incidence of or rates of ischemic heart disease, stroke, peripheral arterial disease, heart failure, and metabolic conditions like diabetes and hypertension were higher in those PBC patients with hyperlipidemia as compared to those without. So the conclusion was, despite a lower all-cause mortality and reduced liver-related complications, the significantly increased burden of cardiovascular and metabolic comorbidities in PBC patients with hyperlipidemia underscores the importance of more personalized and proactive cardiovascular monitoring. This is another related abstract. I didn't use the details of this study, just wanted to show the results. This abstract looked at the use of statins in these PBC patients to see if it is beneficial. And on the left, you can see that the patients who were on statins had lower rates of liver-related events and decompensation rate as opposed to those who were not taking a statin. So my conclusion from these two studies is patients with PBC don't have benign hyperlipidemia, that it does increase their cardiovascular risk, and statins are a great way to treat them because it not only reduces their liver-related complications, but also reduces their cardiovascular events. This next abstract looks at early alkaline phosphatase normalization using a combination of UDCA and bezafibrate. So UDCA is the first-line treatment for PBC, and early normalization of alkaline phosphatase has good prognosis. So within 1 year of improvement or normalization of alkaline phosphatase is associated with better survival. Bezafibrate improves liver biochemistry, and typically it is used as a second-line agent in patients who are incomplete responders. In addition, and it is given in combination. So the investigators here looked at whether early combination therapy versus UDCA alone can impact ALP normalization. And here's the study design. So they had one group with UDCA alone, one group with UDCA plus 800 milligrams of bezafibrate, and the third group with UDCA and bezafibrate 400 milligrams. And after 6 months, they were all converted to 400 milligrams of UDCA. And then they looked at the results. And you can see the baseline characteristics were pretty similar in all three groups, except BMI was lower in the high combination cohort. And these are the results at 6 months. The rate of normalization, ALP normalization, is 100% in the high combination group as opposed to 83% in the low combination group versus UDCA alone. And if you look at figure 4, which is complete response, 57% achieved complete response in the higher combo group as opposed to 47% in the low combo group versus UDCA. And the decline in ALP is much steeper, if you may, in the high combo group. Figure 5 shows you the rates or improvement in pruritus from baseline to 6 months later. You can see after 6 months, 100% of combo group had resolution of pruritus as opposed to um, a smaller percent in the 6 months in the UDCA alone group, 88%. So in conclusion, upfront combination therapy with UDCA and bezafibrate significantly improves ALP normalization as compared to UDCA alone. And the clinical impact of early ALP normalization should be investigated in future studies because it may have significant prognostic factor in terms of liver-related events. Next topic, we'll talk about primary sclerosing cholangitis. So this is a study looking at role of MASLD in driving fibrosis in PSC patients. So as you know, MASLD is associated with increased risk of hepatic fibrosis, HCC, liver transplantation, and all-cause mortality. So the investigators wanted to see the effect of MASLD in PSC patients. So this is, again, a retrospective study using Trinetics database. Adults over 18 years of age diagnosed with PSC between 5 to 20 years ago were identified and divided into two cohorts. There were 506 patients with PSC and MASLD, and over 4,000 patients without MASLD. The primary outcome was fibrosis progression. The secondary outcomes included HCC, liver transplantation, and all-cause mortality. And here are the results. So the cohort with PSC and MASLD were at risk of fibrosis progression 8-folds compared to PSC alone. Other outcomes such as HCC, liver transplantation, and all-cause mortality were similar in the two cohorts. And they have depicted the same results in bar chart and risk ratio here, essentially showed the same thing. So in conclusion, MASLD is associated with 8-fold increased risk of fibrosis progression in PSC, suggesting a synergistic liver injury. And incorporating routine metabolic risk assessment and lifestyle modification may help mitigate liver disease progression in this subgroup. And further prospective studies are recommended. Next, we'll talk about autoimmune hepatitis. So this abstract looked at pregnancy outcomes in patients with autoimmune hepatitis taking azathioprine versus those not taking azathioprine. So women with autoimmune hepatitis have been treated with azathioprine throughout their pregnancy. However, the studies that we have are smaller studies, and there's a theoretical risk of increased risk of teratogenicity. So this study looks at that. This is a Trinetics database. Again, women aged 18 to 15 were identified with autoimmune hepatitis. Comparison groups were azathioprine versus no azathioprine. And these are the results. This shows the baseline characteristics before matching and after matching. You can see after propensity score matching, the baseline characteristics are pretty comparable. And outcomes such as preterm pregnancy, abortion, gestational diabetes, eclampsia, preeclampsia, or suspected teratogenicity were similar in both cohorts. So, conclusion, women with autoimmune hepatitis on azathioprine have similar pregnancy outcomes as those who are not taking azathioprine. So this is very reassuring. Although we knew that, but this large with autoimmune hepatitis end up discontinuing azathioprine because of intolerance. Both 6-MP and mycophenolate mofetil MMF are second-line options, guideline endorsed, but head-to-head comparison is scarce. So the aim of this study was to compare their effectiveness and safety in a large multi-center cohort. So this study includes 211 patients from 11 centers in Europe and Canada. And they included patients who were azathioprine intolerant. They had 106 patients with 6-MP and 105 patients on mycophenolate. They did propensity score matching. Primary endpoint was complete biochemical response. Secondary endpoint, treatment intolerance, need for third-line therapy, changes in liver stiffness, and long-term outcomes. And these are the results. So you can see about a third of the patients who were on azathioprine ended up stopping it, and they were converted to 6-MP or mycophenolate. The largest share of patients complications. Yet data on pregnancy outcomes following liver transplant is scarce. So this study aims to analyze the impact of autoimmune hepatitis-related transplant on pregnancy and fetal outcomes during and after pregnancy. So this is a large retrospective analysis using the Transplant Pregnancy Registry International between 1985 through 2024. They had a total of 11% versus 4%. Other outcomes such as labor type, spontaneous induced C-section, or live birth or miscarriage rate were pretty similar in the two cohorts. On the right, you can see the bar graph showing the immunosuppression. Up to 10% of the patients were exposed to mycophenolate as soon as they found out they were pregnant. They were switched to a different immunosuppression. The larger group were on prednisone. Neonatal outcomes, the AIH cohort babies had high rates of jaundice and NICU admission as compared to control group. And transplant outcomes were similar, except graft loss was higher after pregnancy, about 24% versus 13% in control. So the conclusions were pregnancy outcomes are similar in women following liver transplant for AIH compared to other diagnoses. Neonates of AIH patients had higher rates of neonatal jaundice and NICU admission. AIH patients also displayed higher rates of graft loss after pregnancy, possibly due to shorter liver transplant to conception intervals. And despite higher exposure to mycophenolate, there was no differences in birth defects, miscarriages, or stillbirths. So take-home points, serum IgM levels are an independent predictor of liver-related events. PBC patients with hyperlipidemia are at significantly increased risk of cardiovascular burden. The statins can be used to protect against decompensation in major liver-related events. An upfront combination therapy with UDCA and bezafibrate yields significant higher 6-month ALP normalization rates than UDCA alone. MASLD is I think we skipped this. No, we did. Mast cell is associated with 8-fold increased risk of fibrosis progression in PSC, suggesting a synergistic liver injury. Women with AIH on azathioprine had similar obstructive pregnancy outcomes as women with AIH, not on azathioprine. Both 6-MP and MMF achieved comparable long-term biochemical responses in patients with azathioprine intolerant AIH. And pregnancy outcomes are overall similar in women following liver transplant for AIH as compared to other diagnoses. I want to thank you for your attention. I am happy to take any questions.
Thank you. Thank you so much, Dr. Sajid Jalil. Questions for the audience. It was very clinically relevant about many things that we see in our practice.
Bilal, I think you're muted.
No, can you hear us, Dr. Sajid? Sajid bhai, aapko awaaz aa rahi hai?
I can hear you now.
Okay.
With a little echo.
Okay. First question I have, that the IgM level in your clinical practice, the presentation was
I'm sorry,
at the...
I'm having trouble hearing you.
Yeah, we cannot hear Bilal at all.
Can you hear us?
Bilal, you are muted, I believe.
No, we are not muted. I think, let's see. Yasser, is there muted?
I can
No,
hear you
it's
now.
better now. I can hear you.
On. Okay, can you hear us? So Sajid bhai, the first question about your, the first abstract about the IgM level, is it at the time of diagnosis or you check it on a regular basis? What's your clinical practice for the IgM level in patient with PBC?
You know, this really raised my eyebrows because I've noticed here elevated serum IgM levels, but I've not paid attention until this abstract. I read this abstract. So I'm going to start checking it more. And based on this study, it was early at the time of diagnosis.
Yeah, because I think some people check it on a regular basis, but not all the time. But it's an interesting thing that on the presentation, whether that was can able to do it or not. Any other questions from the audience? Please, do you have a mic to our, can we pass the mic to one of our, please go ahead.
Assalamu alaikum. It was a very nice presentation, Dr. Sajid. The only thing that comes in my mind is in cases of PBC, is there any specific cutoff of lipid levels at which we need to start the bezafibrate or statins? Or is it the usual level of ASCVD classification that we used in other cardiovascular disorders?
Yeah, I think it's the usual ASCVD lipid criteria that we use for cardiovascular mortality. So there's no cutoff that they came up with in this abstract. Basically, the same criteria will use for cardiovascular related.
Professor Altaf.
Right. Thank you, Sajid. An excellent presentation. Good selection of abstracts. We hope to see you next time in person at the next Liver Summit. Bezafibrate is not available in Pakistan. So what I'm doing here is using fenofibrate in its place, and I understand it works equally well. And I've seen the results in either partially responsive patients or upfront dual therapy UDCA plus fenofibrate, and it works very well. I'm not using it for lipid control. I'm using it for control of cholestasis. So even with normal lipid profile, I'm using it for cholestasis. Are you doing the same, or you are only using in those patients who have dyslipidemia?
No, actually, I'm using more and more fibrates in my practice. If alkaline phosphatase doesn't improve despite patient being compliant and taking UDCA, and certainly if they have a higher lipid profile, which we routinely check every 6 months, I'm trying to be more aggressive. Plus, I use statins pretty aggressively. So a lot of these patients also seem to have metabolic dysfunction. So we have to definitely consider statin as part of their treatment armamentarium.
In the US also, we just recently had 2 approval of new medication, seladelpar, and before that we didn't have bezafibrate, so we had some patients going to Canada to get it, or we were using fenofibrate. I had a lot of patients on fenofibrate, but now with the second line therapies have changed, like it is, like I've seen like complete normalization. The pruritus have changed, has improved, so this has changed the field. I'm not sure about the prevalence of BBC in Pakistan and whether there would be need for these second line therapies in the future, but we can see how much improvement patients have, the quality of life, the lipids and everything, so that has changed. So thank you, Dr. Sajid Jalil, for another excellent session. Thank you all the audience, and I will invite Dr. Altaf Alam for vote of thanks, and then we will have a concluding remarks. Thank you, everyone.
Thank you, Bilal. It was an excellent session. And as I mentioned earlier, I would like to see Dr. Qasim, Dr. Khalid, Dr. Sajid, and Dr. Sobia in person for the next Liver Summit. That will make it more interactive and more useful for the participants here. We had a wonderful session, and excellent presentations from all the 4 presenters. So I thank all of them for their time and for their effort. And as I said, hope to see you next time in person. I also would like to thank all the national faculty here for yesterday's presentations and the audience for their active participation. In the end, thank you, Feroz Sons, for organizing such a wonderful meeting. We have some suggestions for next time to improve the quality of the meeting, and certainly we'll be sharing it with you, and we hope that we improve with every year. Thank you very much, everyone.
Thank you so much, Dr. Altaf Alam. Yes, we will try to improve it much better next time, inshallah. So now we are moving towards our certificate distribution ceremony. Thank you so much, first of all, our scientific committee and our panelists, our speakers, our moderators. So for certificate distribution, I would like to invite Dr. Altaf Alam on stage. Sir Yasir, Sir Faisal Salim, Dr. Mohammed Saleh, Dr. Qiyasun Nabi Tayyib, So firstly, Dr. Bilal, thank you so much for your support, for being our core member of our scientific committee and as a speaker and moderator. So thank you so much. So we are presenting a small token of appreciation to you. Dr. Altaf Alam, thank you so much, sir. Without your support, it was never possible. So thank you for being our core scientific committee member, our speaker, our panelist. Thank you so much, sir. Dr. Riazun Nabi Tayyab, thank you so much, sir, for being our core member of scientific committee and our panelist and our speaker. Dr. Javed Iqbal Farooqi, thank you so much, sir. Please come on stage and join us for receiving the token of appreciation and as well our award distribution ceremony. So Dr. Javed Iqbal Farooqi was also a core member of our scientific committee. Thank you, sir, for being our core member of scientific committee, our speaker, our panelist. Dr. Mohammad Saleh, thank you, sir, for being our core member of scientific committee, our speaker, and our panelist. I'm thankful to our all panelists as well, Dr. Asif Peek, our international panelist and moderator. Thank you so much, sir, for joining 12th Liver Summit and for your contribution. Brigadier Dr. Amjad Salamat, please come on stage for receiving token of appreciation. Thank you so much, sir, for joining our 12th Liver Summit and for being our distinguished panelist. Dr. Shumai Zafar, please come on stage for receiving a token of appreciation. Thank you so much, sir, for joining our 12th Liver Summit and being our distinguished panelist. Dr. Mauzuddin, thank you so much, sir, for joining 12th Liver Summit and being our distinguished panelist. Please come on stage for receiving token of appreciation. Dr. Zishan Ali, please come on stage for receiving token of appreciation. Thank you so much, sir, for being our distinguished panelist at 12th Liver Summit. Dr. Zahid Azam, please come on stage for receiving token of appreciation. Thank you so much, sir, for joining 12th Liver Summit and being our distinguished panelist. I'm also thankful to our all three moderators, Dr. Akram Malik, Dr. Adil Hassan Chung, and Dr. Asif Peek. Two of them are not here. I would like to invite Dr. Adil Hassan Chung on stage for receiving token of appreciation. Thank you so much, sir, for your support, for being our moderator at 12th Liver Summit. I would like to invite our speakers and panelists and our faculty on stage so we can have a group photo as well.
I request you all to please come on a stage for a combined group photo. Frozen's team members are also requested to come and join in the group photo.